keep myself from being overwhelmed, what I would do is, at minimum, after you cover an endocrine organ and all the hormones from that organ, you would go home and make sure that you had everything about that one filled in on your table, right? Because otherwise you are going to be left with this pile of information that is disorganized, right? And it's going to be way harder to memorize it if you haven't like taken that out in little pieces, okay? So, and in addition, I want you to understand that that table is only part of the endocrine system. After we learn all of the endocrine organs and all of the targets and all of the functions and all the names of the hormones, then we have to go back and learn the physiology, like how do you cause the release, how do you inhibit the release of those hormones, okay? So a lot of times people wait until the last minute, they memorize the whole damn table, and then they realize, okay, I've got this memorization, but I don't actually have any logical understanding of what the hell it's talking about, right? So that's going to take a little time for me, because I'm a crappy memorizer. I'm a terrible memorizer. Memorization takes longer than understanding things to me. So, but I'm going to try to give you as many tools as possible so that the names of the hormones mean something. So you have to do less memorization. Okay, so today, before we get into the interesting stuff, we have to start with the boring stuff. And the boring stuff is just when you are looking at hormones, the first thing that I want you to understand is that the hormones fall into one of 4 chemical categories. Why the hell do you care about the chemical categories? Because if you're lipid soluble, you're going to find your receptor in a different place than if you're water soluble. Yes? Okay. If you're lipid soluble versus water soluble, any idea? I mean, you might not know this, but you can probably like come up with a hypothesis about it. Which one do you think is going to be more persistent in the body, like gets cleared more slowly, lipid soluble or water soluble ones? Lipid soluble ones tend to persist for longer. They have a longer half-life. They stay around for longer. They don't get cleared by your kidneys very well. Does that make sense? It tends to be true with lipid soluble stuff. And then the other reason it matters is because clinically, since you guys are going to generally go into something related to clinical stuff, if I have a lipid soluble versus a water soluble hormone and I have to replace it back, like I have a deficiency, so let's say I've got a peptide versus a lipid soluble hormone. If I am deficient in a peptide hormone like growth hormone, can I take a growth hormone pill? What happens if I take a peptide pill? It's broken down to amino acids, right? And it's just like the most expensive protein supplement ever, right? So what do you tend to have to do with peptide hormones to replace them? You have to inject them. You have to like bypass the digestive system. Insulin, for instance. Does that make sense? Okay. If I am, however, deficient in a lipid-soluble hormone, I have a lot of possibilities for adding it back. I can orally, for instance, take estrogen, progesterone, or thyroid hormone. I can use a patch for testosterone, right? I can sometimes like rub a cream on it because it's lipid soluble. So the chemistry of the hormone ends up having some clinical significance. So what we're going to do right now is just learn the 4 basic categories that they fit in. And it's going to be easy. You're going to have peptides, right? You're going to have amino acids, but there's a lipid-soluble amino acid and water-soluble amino acid. And then you're going to have this group called steroids. And I don't know if you know what steroids means yet, but you will in just a minute, okay? All right, so the chemistry of the hormone, as I mentioned, will determine where the receptor is, whether a transport protein is required for circulation. If you are a lipid-soluble hormone, sometimes it's difficult for you to get from point A to point B without getting distracted, right? Lipid-soluble things, like I'm trying to go all the way over there, but ooh, look, shiny object, and you just diffuse straight out here. So a lot of times what they need is someone to hold their hand. It's generally a protein made by the liver to make them temporarily insoluble until they get where they need to go. Does that make sense? Okay. And water-soluble hormones decompose more quickly than lipid-soluble ones, so you need to tend to make those more often. Okay. All right. So let's talk about the 4 categories. Okay. Amine hormones tend to end in INE. Okay. So that's easy, especially because you've already met the first 3, but you met them as neurotransmitters. So if a hormone ends in INE, it is telling you that it's an amine hormone. And then all you have to do is figure out whether it's lipid-soluble or water-soluble, but that's pretty easy too. So let's look at the amine hormones. You've already met 3 of them because you met them as neurotransmitters. Remember, these were all derived from tyrosine, but now dopamine, norepinephrine, and epinephrine are being used as hormones. Does that make sense to you? Okay. Now, dopamine, norepinephrine, and epinephrine. So please note that you have to know how to spell them in order to get that trigger that it's actually an amine. Because in the United States, we say norepinephrine and epinephrine, but if you're British, you say norepinephrine and epinephrine. And probably, did you say it that way too?
Yeah, that's what we say.
Yeah, and it's actually probably the right way to say it. We just took a beautiful language and bastardized it and then pretended it was ours. So norepinephrine and epinephrine. Does that make sense? Okay, you don't have to say that because you're going to sound really pretentious if you're an American and you say that, right? You can't get away with that, right? Ain't nobody think that I went to a posh school. It's not. I can't convince anybody of that. Okay, so epinephrine and norepinephrine are hormones, and as hormones, you already know where they're released from because we talked about it in the last set of notes. Epinephrine and norepinephrine. As a hormone, they are released from where? Adrenal medulla. Yes, you knew that. Yeah, just putting it together. Okay, and then dopamine. We know it is a neurotransmitter, yes, but of course, as a hormone, it's released from two different endocrine organs. One of them is the adrenal medulla, and the other one is the hypothalamus. Okay. All right. Now, there are two lipid-soluble amines that fit into a category kind of by themselves, lipid-soluble amines. They both come from the thyroid. I don't want you to try to write down the long name because we'll learn it later when we actually do the thyroid. The abbreviation for them is T3 and T4, but just listen to the long name, okay? And hear that it's telling you that it's an amine. T3 is triiodothyronine. Triiodothyronine. Does that make sense? Okay. And T4 is tetraiodothyronine. And it won't surprise you at all that one of them has 3 iodines as part of it, and the other one has 4 iodines as part of it, and we'll learn that later, okay? So T3 and T4 both come from the thyroid, okay? So you've got 5 amine hormones. 3 are water-soluble, 2 are lipid-soluble. And then we run into the peptide or protein hormones. Your textbook says peptides are like just a few amino acids stuck together with peptide bonds, and proteins are bigger. Just lump them together. If you got more than 3, right, amino acids stuck together by peptide bonds, they're all going into the same thing. Why do they separate them? Well, because if you get bigger, you tend to be a little slower with diffusion, but they're all like the same kind of thing. So before we go any further, remind me that you remember 1610 better than the last class, preferably, and tell me if it is a peptide. First, is it water-soluble or lipid-soluble? You know that, right? That's why they don't all diffuse straight out of the cell when you make them. It's water-soluble. Where would they find their receptors on the target cell? Cell membrane, good. And where would they be made in the target cell? The cell that makes the peptide for secretion makes it on what organelle? You can do this. I know you can. 1610, brush it off. Cobwebs, get out of the way. Oh, you are my favorite today. Rough ER, yes. Rough ER. I'm very fickle. But today, I always tell my kids that too. When the other ones aren't in the room, I just tell every single one of them they're my favorites. Okay, so rough ER. And then if it's for secretion, you're generally going to package it up in the Golgi and secrete it by exocytosis. Why exocytosis? Because it's big, yeah? It's all the same story. Okay, so here's the rule with peptides. Any hormone that ends in IN is a peptide, but they don't all end in IN, okay? So if it ends in IN, it is a peptide, okay? But they don't all end in IN. I'm sorry they didn't get their crap together with name and stuff, right? They didn't do it for me either. But this also means that you need to know that norepinephrine is not spelled that way, right? It's actually got an INE, okay? All right, so let's talk about the peptide hormones. By the way, peptide hormones are by far the most abundant, so if you forget on a test or a quiz, just guess peptide. It's the most likely right answer, okay? The peptide hormones include hormones from the following organs, and we're going to go through some of these. We won't get to all of them today. The hypothalamus releases 7 different hormones, and all of them except for dopamine are peptides, okay? Because dopamine is a what? It's right there in the name. It's an amine, exactly. And the posterior pituitary, we're going to learn those 2 today. Those two are called oxytocin. That's helpful, right? And then the other one is ADH, but ADH's other name is vasopressin. Okay? All right. And you'll learn all of these. Pancreas releases 3 hormones. 2 of them are named properly, and one of them is just trying to jack with you. Insulin, yes. Somatostatin, and glucagon. Get with the program, glucagon. It ain't gonna. Okay. And then parathyroid hormone, just PTH. It's not named properly. And then most of the hormones from the anterior pituitary. You're going to learn 6, and all 6 of the hormones from the anterior pituitary are peptides, whether they end in IN or not. Okay? And then there's some other organs. Most organs, if you had to guess, just guess it's going to be a peptide. If I didn't teach them to you in the notes, then you don't have to know them specifically, but sometimes, for instance, when we get to the cardiovascular system, we'll add one more hormone, right? And when we get to the urinary system, we'll add another hormone, okay? And guess that they're peptides unless somebody tells you otherwise, okay? And then the last category of hormones are called the steroid hormones. And people get really confused about what steroid means. Steroid means that it is lipid soluble and derived from cholesterol. How many of your cell membranes have cholesterol in the cell membrane? All of them. You're an animal. Animal cell membranes have cholesterol in them. So theoretically, every single cell that you have could make a steroid hormone. What people get confused about is that they think that steroids are exclusively sex hormones, but they're not. The sex hormones are steroids, but not all steroids are sex hormones. Okay? Okay, so let's look at them. So let me just show you what cholesterol looks like. That's what cholesterol looks like. A ring structure. If you want to know all the carbons, you can. Most of you guys haven't had organic yet. Some of you have. Okay, and then with testosterone, it looks very similar to that. And then basically, they're all really similar to this with some groups added or subtracted, and they're all going to be lipid soluble. So let me just introduce you to for the first time to all of the steroids. You don't have to memorize them now. Okay. So the steroids include all of the male hormones, okay, in blue. They're not exclusive to males, but they're in higher concentration in males. Those are collectively called the androgens. Is that okay? Andro means male, okay? The female hormones, which are collectively called the estrogens, yes, okay? Progesterone is made a little differently. It's a higher concentration in females. I don't even know if males have progesterone. Never actually thought to look about that yet. So progesterone. So pink for girls, blue for boys, but realizing that we both have some of each. And then these are, regardless of your sex, you release about the same quantity of those. Okay, so that's what color you paint the baby's room when you don't know what it's going to be, right? You paint it green, okay? So those are sort of your sex-neutral hormones that you've got. And these are all derived from cholesterol, notice, okay? Also notice that estrogens are actually derived from androgens, which is kind of an interesting thing. We'll talk about the impact of that a little later. Okay, so the steroid hormones, they are not stored. Where would they be made, by the way, in the cell that makes them? Where are you made? Lipids. Oh, 1610. I'm going to go tell your 1610 teachers. The smoothie R? Smoothie R is primarily responsible for making lipids. Okay, they're really difficult to store. They're usually made and released and made and released and made and released. Why would it be difficult to store them? Because they're lipid soluble, right? It's like all the doors are open all the time. They just diffuse straight out of the cell. So they're generally made and released and made and released and made and released. And they're going to, when they get to their target cell, they're going to go straight through the cell membrane and find an intracellular receptor, right? Could be in the cytoplasm or in the nucleus, whatever. And the primary places that they are released from are the adrenal cortex. We'll get there. And of course, the ovaries and the testes make the sex-related ones. Also the placenta for a little while, and the kidney makes one too. We don't usually study that one though. And so generally speaking, there are 2 big categories that we study. We study the corticosteroids, or if you're British, corticosteroids. And those all come from the adrenal cortex. And then we study the gonadal steroids that come from the gonads. Does that make sense? So not surprisingly, these come from the adrenal cortex, yeah? And these are most likely to come from the gonads, although there is a little bit of overlap. Is that okay? Okay, so we'll come back and pick those up later. So your assignment is to fill in the chemical class of hormone on your endocrine table. And you've got most of that information now, just from what we just went through. Okay, we're going to go through them specifically as we go through each endocrine organ. There are 4 possible answers that go in that column for chemical class. They are steroid, right? Water-soluble amine, lipid-soluble amine, or peptide. Good? Okay, so one last little tidbit before we get into the interesting stuff, and that is hormone transport in the bloodstream. There is a difference between how lipid-soluble ones and water-soluble ones are transported. Okay, so let's say this is a peptide, yeah? Water-soluble peptide. It would be secreted by exocytosis into the interstitial fluid, and then generally this is a fenestrated capillary, it gets picked up, and then it just goes from point A to point B, and it doesn't need any helpers. But when you are a lipid-soluble one, you're secreted by diffusion. Does that make sense? You go straight into the bloodstream. But to get from point A to point B without getting distracted, a lot of times you need a protein to hold on to you and make you temporarily insoluble. They call this a carrier protein, but I hate that because carrier protein means something different to me. Carrier protein means a transport protein, usually cell membrane based, right? So I call it an escort protein because that's a little sexier, right? Or chaperone if you disapprove of all things sexy, right? Okay, whatever. You go ahead and choose yours. So it is a protein usually made by the liver. The vast majority of these are made by the liver. And what they do is they temporarily hold on to it to make it lipid insoluble, and then when it gets to the target cell, they have to let it go again because, of course, it can't get inside the target cell to the receptor. Okay, so now with that in mind, in order to figure out if a hormone is going to behave properly or is behaving properly, you have multiple things to look at. You say, okay, is it the Goldilocks level of the hormone? You're secreting the proper amount, or too much or too little, right? So that's one thing that could be a problem. And then is it being over-metabolized or under-metabolized? Is it being over-excreted or under-excreted, right? And then if it's lipid-soluble, you have to figure out whether it's being bound properly and unbound properly, right? If it's being bound too much, right, or bound too little, you're not going to carry it very far. Or you could not let go of it, right? And then you would treat that differently than just a hypo or hypersecretion. And then once you finally get it to the target cell, is the receptor behaving properly, right? Is it going to activate the signal transduction pathway that you wanted it to? So it's pretty freaking complicated. Okay, so now let's get into the interesting stuff. And you have to listen really carefully today because the naming convention is super confusing until you get the pattern. And then once you get the pattern, you're going to be cool, okay? So first thing is let's talk about the fact that not all endocrine organs are glands. Okay, so we generally refer to things as endocrine glands, but they're not all glands. So like the pituitary, part of it is glandular and part of it isn't, and the pancreas is glandular and the thyroid is glandular, but the heart also releases a hormone and it's not a gland, right? And the kidney releases a hormone and it's not a gland. So if you really want to be correct, you just call them endocrine organs. And it's kind of a circular definition because what's an endocrine organ is something that releases a hormone. What's a hormone? Something that comes from an endocrine organ. So, but we do know what a hormone is, right? What makes it into a hormone? Travels to the bloodstream. Secreted from one cell, travels to the bloodstream to get to its target cell, right? Okay, so not all endocrine organs are glands. We will talk about the major endocrine organs as we go through. There are others for sure. Okay, so let's start with the hypothalamus. The hypothalamus kind of gets to command a lot of what else goes on. So let's remind you where your hypothalamus is, right? Here's the hypothalamus right here in the brain. Remember when you were in anatomy, you're like, that? And then it does every damn thing, right? It just does everything. And we will see that the hypothalamus secretes 7 different hormones, plus makes 2 more and doesn't secrete them. And it controls all kinds of crap by doing that, in addition to its nervous system functionality. So the hypothalamus is really the intersection between the nervous system and the endocrine system, right? It's really where the 2 of them come together. And we will see how it decides what to secrete. So the hypothalamus is right here. And remember, of course, that the pituitary gland hangs off of the hypothalamus, right? Okay, so let's start with hypothalamus hormones. First, I want to show you something, and I want you to pay attention because this can get confusing if you don't. Okay, so the hypothalamus is connected to the pituitary gland via the infundibulum, that stalk, right? Okay, you see it right there. Okay, but it has a connection to the posterior pituitary and the anterior pituitary. First, let me tell you that if we had histology when we named the pituitary gland, we wouldn't have named it one gland because it's actually two different organs that are just roommates in the sella turcica. That's it. And one of them is actually nervous tissue, that's the posterior pituitary, and the other one is glandular tissue. So let me introduce you to it, okay? Here's the hypothalamus, yeah? This is the optic chiasm right here, right? You're oriented, okay? And the posterior pituitary is really just a white matter extension of the hypothalamus. It's just nervous tissue with a capillary bed at the end. Does that make sense? So if we had named it when we had histology, we would have just said that's still part of the hypothalamus, okay? So the posterior pituitary. And what's going to happen is you are going to make two different hormones up here, and you're going to release them just like they were neurotransmitters after an action potential, only they go into the bloodstream, so they end up being hormones, okay? But these two are not actually considered hypothalamus hormones because they're actually released from the posterior pituitary. They're made in the hypothalamus, released from the posterior pituitary. And they are called ADH and oxytocin, and I will talk about them when I talk about the posterior pituitary, okay? All right, but I want you to look at the difference between this connection between the hypothalamus and the posterior pituitary and this one, which is the hypothalamus and the anterior pituitary. Please note that the hypothalamus and the anterior pituitary, this is a neural or nervous system connection, yeah? This is a vascular connection. So what happens here is I make 7 different hormones, release them into this capillary bed. They go through the bloodstream to this capillary bed. Does that make sense? So that's a vascular connection. This tissue up here is actually glandular tissue. The anterior pituitary is totally different. So they're roommates. They're totally different than each other. The anterior pituitary is a gland. The posterior pituitary is a continuation of the nervous system. And this is a weird pattern of circulation, right? This pattern of circulation has 2 capillary beds in series connected by a portal vessel. Okay, portal vessel. You remember learning about a portal vessel in anatomy? You don't? The hepatic portal system, okay, here's what a portal system does. It breaks the rules of cardiovascular pattern. Cardiovascular pattern generally goes heart, arteries, arterioles, capillary, venular vein, heart, yeah? But a portal vessel does this. Heart, arteries, arterioles, capillary, portal vessel, capillary, venular veins, heart. What it does is shunts everything that happens in this capillary to that one before it goes into circulation, right? And we'll see that that's going to be really important here. Okay, so what we are going to talk about is the hormones that are released here to go here, right? They're all going to be released from the hypothalamus to go to the anterior pituitary, and there are going to be 7 of them. Before we get to the details of the 7, I have to teach you a little bit of terminology. If you ever see this suffix, tropic or tropin, it means target. So if I tell you the name of a hormone is thyrotropin, what am I trying to tell you? Targets the thyroid. Yes, thyrotropin. Okay, so thyrotropin goes to the thyroid. But, and this is important, if I add another word to it, it changes the meaning. So listen to this. Thyrotropin goes to the thyroid, but thyrotropin releasing hormone does not go to the thyroid. It causes the release of a hormone that is going to head to the thyroid. So it's one step back, okay? You got it? Okay, and I'm going to show you this as we go through, and I'm going to reinforce the pattern and ask you about it as we go through. Just remember, if it's a releasing or an inhibiting hormone, you got to go one step back, okay? So eventually we're going to build these chains. Okay, so what we are going to do is all of these hormones that we are about to do are all going from the hypothalamus to the anterior pituitary. The fancy name for the pituitary is hypophysis. Hypophysis. So just listen. All of these hormones are going to be called hypophysiotropic hormones. Why? Because they're all headed to the hypophysis. Okay? All right. So now let's look at, I love this particular diagram. There's so much information in such a small space. Okay. So notice what we're doing here. This entire top purple box is the hypothalamus, and everything from there is going to the same box, which is the anterior pituitary, yeah? And then the anterior pituitary is going to respond by releasing things to different places in the body. Does that okay? So we're going to do this box first. Notice that all of these are basically neurons that are going to dump something into the bloodstream, right? Okay, so the hypothalamus is really going to control the function of the anterior pituitary by releasing 7 different hormones into those portal vessels right here. And it's going to go straight here. Now, the hormones that I make here tend to be released in very, very low concentrations compared to the hormones that go in the rest of the body, because notice it's going straight from point A to point B and not pass and go. So these are really difficult to detect too much or too little of unless you go to an endocrinologist. They're also really difficult to replace because you have to deal with the blood-brain barrier if you're still in the hypothalamus. So a lot of times they don't even treat it here, they'll treat it here instead. So we'll come back to that when we deal with disorders. Okay, so the hormones that are going to go from the anterior pituitary to the hypothalamus are either going to, cause the release of or inhibit the release of something. Does that make sense? Pluses and minuses, you got it? Okay, from the anterior pituitary. Okay, so I'm going to start teaching you the naming convention. And I want you to pay more attention right now to listening than scribbling, because you know you can look up what these abbreviations stand for at any moment, right? Okay, so I just want you to hear what we're talking about. So we're going to talk about these. So the first one we're going to do is right here, which is GHRH. I want you to listen to the name of it. So this hormone is called gonadotropin releasing hormone. Where is it headed? You would think that, except that it's a releasing hormone, right? So it is going to the anterior pituitary to cause the release of something headed to the gonads, yes? So it's not a gonadotropin, it's a gonadotropin releasing hormone, right? Does that make sense? Okay, so it causes the release of something headed to the gonads, okay? It's headed to the anterior pituitary to cause the release of gonadotropins. Got it? Okay, so let's do the next one. Next one is TRH, which is this one right here, okay? Its long name is thyrotropin releasing hormone. Where's it headed? Anterior pituitary. You're quick, right? And what does it do? Causes the release of something headed to the thyroid, right? Eventually you'll know what the something is. You just don't yet. Does that make sense? And look at the picture and see if that makes sense. Causes the release of something headed to the thyroid. Yeah? You got it? Okay. And then as soon as you get the pattern down, the bastards have to change it. Sorry. Now, this one has 2 names. The first name is only helpful because it tells you the chemistry. Somatostatin, which tells you the chemistry, right? Okay. And the second name really sort of tells you what it does. And the second name is GHIH. Okay. It sounds like an oxymoron. It's weird. Growth hormone inhibiting hormone. Growth hormone inhibiting hormone. Where is it headed? Anterior pituitary, because everything is headed to the anterior pituitary. And the name is telling you what it does. It blanks the release of blank from the blank. Inhibits the release of growth hormone from the anterior pituitary. Got it? Okay, not do you like it, but did you understand it? Right? Oh, I had the hardest time with endocrinology when I was taking phys, especially in grad school, because I did not get the pattern. So I had to go, and I just memorized it all, and I'm a terrible memorizer, so I just dropped out of my head holes as soon as I breathed. And then I went back and it's like, oh, there's a pattern here. I've got it. And if I can find a pattern, I can remember any damn thing, right? Okay, so this is growth hormone inhibiting hormone. And then let's do the next one. CRH, so CRH. So listen to this one. This one is corticotropin releasing hormone. Corticotropin releasing hormone. Where is it headed? You're not going to let me fool you again, are you? I'm going to write that on a quiz, and then you guys are going to choose something else, right? Corticotropin releasing hormone. And what does it do? Find the relevant cortex in your brain. Relevant cortex for endocrinology. What's the relevant cortex? I mean, you got cortexes all over the damn place. This one's the adrenal cortex, right? Okay, so now what does it do? Corticotropin releasing hormone. Causes the release of something headed to the adrenal cortex from the anterior pituitary. Got it? So you hear those little blurbs that I'm saying? Those little blurbs are what go in the effect column. Is that what I called it? I can't remember. What's it called? The effect, right? So you didn't need a paragraph in the effect column because you're not going to remember 32 paragraphs. You need a blurb, right? Does that make sense? Okay, so we've been doing those blurbs. That's what we've been doing. We've been making it simple enough that you are going to be able to talk about it, right? Does that make sense? Okay, so corticotropin-releasing hormone, we got that one. Okay, you'll be able to do GHRH because we just did GHIH. GHRH, growth hormone-releasing hormone. Where's it headed? You just want to flip me off for saying it, though, don't you? But then I'm going to put it on a quiz, and you're going to get it wrong, damn it. Growth hormone-releasing hormone. And what does it do? Causes the release of growth hormone from the anterior pituitary. Okay. By the way, my students kick ass in pathophysiology because I forced you to understand endocrinology. And patho has a lot of endocrine in it, right? Because if your hormones are jacked up, how many different diseases can manifest? So many. So you're going to hate me for a little while, and then later on, you're going to write me a thank you note and send me a present. Okay? Happens every damn semester. Okay, you're like, and sometimes they say, I literally hated your guts the entire time you were talking about endocrinology. I was like, that's all right, I didn't like you either. Okay, so next one is called dopamine, okay? And that just tells you its chemistry, but it doesn't tell you its function. Yes? Dopamine. Its other name is prolactin inhibiting hormone. Prolactin inhibiting hormone. Where's it headed? Anterior pituitary. And it's not really telling you the target, but it's telling you what it does, right? It's telling you it's going to do what? Inhibit the release of prolactin from the anterior pituitary. You got it? Okay. All right. Close to being done with these. And then PRH is pretty easy because you just did PIH. PRH is prolactin releasing hormone. Where is it headed? Anterior pituitary. What's it doing? Causing the release of prolactin from the anterior pituitary. Okay, all right? So that is those 7. Luckily, they're all going the same damn place, but just to make sure that we all know where they're going, what is the target for each of the above hormones? Anterior pituitary. And I'm going to write one of these on your quiz, which is going to be next Thursday, and it's not going to get 100%. And you want to flip off the people in your class. What the hell? Really? Yes. Okay, so the chemical class of hormones for all of these hormones is they are all peptides except for dopamine, which is a amine. Be more specific. What kind? Water soluble. Water soluble amine. Yes? Okay. So your assignment, fill in the columns with hormone released and abbreviation, alternate names. So for me, FYI, you're going to hate it, but it's going to happen. You have to know the name of the hormone, the abbreviation, and if there is an alternate name, you have to know that. Why the hell am I torturing you that way? Because clinically, they are going to refer to it as TRH or CRH. But that doesn't tell you a damn thing. That's just rote memorization. Then you have a smart patient who says, what is CRH? And you're like, I don't know, it's that box on the thing. And then you lose all credibility with your smart patients, right? You lose all credibility. If a nurse tries to tell me to do something, or heaven forbid, a doctor does, and they don't know what the hell it stands for, I do not comply at all. Because I'm like, if I am more educated than you about this, I will make my own damn decisions. Thank you very much. So I'm a pain in the ass, basically. And you will be too, because you're going to be educated enough. Okay, so now what we are going to do is of course, do the anterior pituitary. That's the place we should go, right? Okay, so first let's acknowledge the pituitary for a second, talk just a teeny bit more about it. So in phys, because the pituitary gland is actually 2 roommates, you can't get away in phys with talking about functionality without saying anterior or posterior. They're different, they do different things, they make different hormones, right? So you always have to say anterior or posterior. Now I told you that hypophysis is pituitary, okay? But there's actually 2 different pituitaries. You have the anterior pituitary, which is called the adeno hypophysis. Adeno means gland, so it's actually the glandular hypophysis. During embryonic development, where does that one come from? What happens, interestingly, is that the posterior pituitary during embryonic development, before you had a skull, it actually just grows out of the brain, right? It's part of the brain. That's the posterior pituitary. But the anterior pituitary actually grows up from the roof of the mouth, the epithelial tissue of the roof of the mouth. And they just end up, right, living together, right? Like two roommates who don't have a damn thing in common, right? They're like, hey, how are you? And they're not even really connected to one another by anything special. They don't have any direct vascular connection or anything. So adeno hypophysis and neurohypophysis, which is the posterior. Does that make sense to you guys? Okay, so we're going to do the adeno hypophysis first. And the adeno hypophysis, one more time, is connected to the hypothalamus via this portal vessel, right? Two capillary beds in series. Unfortunately, they cannot figure out what the hell to call that portal vessel. So if you see a portal vessel in the endocrine system, that's the one they're talking about. And it's between the hypothalamus and the anterior pituitary. And sometimes they call it the hypophyseal portal vessel. And sometimes they just want some more syllables, and they call it the hypothalamo-pituitary portal vessel. Or sometimes the hypothalamo-hypophyseal portal vessel. Right? You just throw that out and you know you're getting your money's worth, right? You're like, hell yeah. It's just baffling them with bullshit is all it's doing. Okay, so now let's talk about the hormones here. So we've already sort of seen the story that we're going to tell. By the way, they call the anterior pituitary the master gland because look how many different places in the body it actually directly controls. And then if you know that this one and this one control other functionality in the body, it ends up controlling a lot of what goes on in the body. It secretes 6 different hormones that go a bunch of different places in the body. But I would argue that the master has a master, right? What's the master's master? Hypothalamus. So this, you know, this is like George Bush II. And who was his boss? Cheney. Right? Behind the scenes, running the whole damn thing, right? That's who it is, right? So this is really the master, but they call the anterior pituitary the master gland. Okay, so let's learn its hormones. So it secretes 6 different hormones. There are actually more than 6, but some of them we don't understand well enough for you guys to learn. You may learn them at some point in your career. Okay, so let's start over here. These 2 right here are collectively considered gonadotropins. Can you see why? Gonadotropins, okay? Because they're headed to the gonads. And the only thing I don't like about this figure is that this is misleading. They don't both do the same thing. Okay, so they are FSH and LH. Let's learn them, okay? So I don't know how much you know about the whole meiosis in humans thing, but FSH, did any of you guys ever learn that the thing that supports meiosis and developing gametes is called a follicle? Did you know that? Okay, so this is FSH, which is follicle stimulating hormone. And what it does is it stimulates the development and maturation of a follicle and ultimately causes oogenesis in a female and spermatogenesis in a male. Does that make sense? Okay, so it's called follicle stimulating hormone. And it's going to make the gonads, assuming you know what gonads are, right? And you called somebody that on the middle school playground, so I know that you know, right? Oh my gosh, they're like flinging words around like gonads and smegma. And I teach at my son's school, and I'm just like, I'm gonna tell them what that means. I'm like, you know that the smegma is between the head of your penis, and they're like, oh my God, shut up! And then they don't call me like that anymore. I'm like, okay, you want to talk about what gonads are? And they're like, no, I don't. Okay, so it causes the secretion of, causes gamete development in the gonads. Do you know what a gamete is? I mean, I know you have, but you might have to brush it off. Tell me what a gamete is. Okay. Go ahead.
So there's undergone meiosis and they have half as many chromosomes?
Yes, a haploid cell, half as many chromosomes. In males, it would be spermatozoa. In females, it would be an oocyte or ovum. A little different in females, but okay. So it causes development of the gametes in the gonads. So basically, now you got your sperm or eggs, right? But sperm or eggs will not work without hormones. So the other hormone that you've got right there also goes to the gonads. It goes to different cells in the gonads, and that one's called LH. LH is a luteinizing hormone, and luteinizing hormone actually causes you to make your sex hormones. So in males, it will cause you to make testosterone and other androgens. Do you know the term androgens? Andro means male. It's the sort of high concentration in male hormones, those blue ones that we saw on the chart. So it causes you to make the male-ish hormones, including testosterone. And in females, luteinizing hormone causes you to make estrogens and progesterone. Which I have got to figure out where the males have any progesterone. Now I just desperately want to know. Somebody want to look it up? So estrogens and progesterone in females. Okay, so collectively, those two make you junk, be able to make some more people, right? Okay, and they do a lot of other stuff too. We'll talk about the function of androgens and estrogens later. Androgens are really, really interesting hormones. Okay, so growth hormone. Growth hormone, the other name for it is somatostatin. And somato means body, right? So, sorry, not somatostatin, somatotropin. Somatotropin. Somato means body, and tropin means target. So it's telling you that it's just going everywhere in the body. What does it do? Well, it's a growth hormone, so does it surprise you that its primary thing is that it causes protein synthesis and cell division almost every damn place in the body, right? It also does some special stuff to the liver that I never test you on. Basically, it makes the liver release paracrine agents that support growth, okay? So this goes almost everywhere. And of course, growth hormone is going to be really, really important during childhood and embryonic and fetal development. And you're gonna have more of it during those times. But during adulthood, you still need it because it actually allows for you to do repair and replacement of things that you lose. And if you don't have adequate levels of growth hormone, you're going to have trouble with healing and regeneration of tissues. Does that make sense? So it's still important. You just don't need as much of it. Okay, so and we'll talk about it a little bit more in a minute. Okay, and then TSH, also called thyrotropin, is right here. TSH is thyroid stimulating hormone. Its other name is thyrotropin, which tells you that it's what kind of chemical? In peptide. Okay. Where is it going? Thyroid. And what it's going to do, we will figure out, is cause the release of your thyroid hormones, the T3 and T4 that we talked about before. Okay, so that's thyrotropin. It's going to the thyroid gland, cause the release of thyroid hormones. Okay, and then two more. Prolactin is not telling you the target, but it's certainly implying it, right? Prolactin, prolactation. Primary target is breast. Yes, so we have known its function in the breast for a long time, but it's actually got other functions that we just figured out recently. So prolactin, yes, of course, goes to the breast, and it goes and causes milk production, not milk let down, but milk production. And then we couldn't figure out why, when women were not breastfeeding, they had prolactin, or why men ever had prolactin, right? Although men can lactate. You're just not very good at it. Sorry, guys. So it also is released as a reward for sexual acts. So it's released during orgasm in both males and females, and it goes into the bloodstream. And it's part of the chill out. In addition to GABA going on in the CNS and stuff, it's actually released into the bloodstream, and it sort of drops your blood pressure and makes you feel good for both. So orgasms are just like this big chemical party, like CNS, PNS, and hormonal. Like it's all over the place. It's just like massive amounts of chemicals released. Okay, so now last one is ACTH. ACTH is adrenocorticotropic hormone. Where's it headed? Adrenal cortex. Yes, it's going to the adrenal cortex, and what it will do is cause the release of cortisol ultimately. So let me give you a preview of things to come, because you're not ready for this yet, but I want to show you what you will need to do eventually. So eventually, instead of just memorizing hormones individually, what you're going to do is you're going to learn the feedback loops for the hormones, right? And you're going to learn feedback loops for all of the hormones, but there's not going to be 32 different ones, because let's just do the thyroid story for a second, okay? So if we're talking about regulation of thyroid hormones, the organ that we start with is the hypothalamus, correct? Yes? And then let's tell a little bit of that story. I'm telling the thyroid story. The relevant hormone coming from the hypothalamus is TRH, yes? Thyrotropin releasing hormone, yes? And then thyrotropin releasing hormone, where's it headed? Anterior pituitary. And what does it do? It causes the release of TSH, yes? Thyroid stimulating hormone, or thyrotropin, that is going to the thyroid, yes? And we don't know this part yet, but I'm going to tell you this part, okay? And then the thyroid will, in response, secrete T3 and T4. Now, ultimately, what you are going to have to do is make this into one story that regulates your thyroid hormone levels. And how would you do that? Well, as soon as I get enough T3 and T4, it will feed back to tell me that I don't need as much TRH and TSH. That make sense? Okay? And then if that's working really well, then what happens to your thyroid hormone? If this is my ideal range, it goes up and down within the range. Does that make sense? Okay, so ultimately, by the time we're finished with all of our hormones, you will have the feedback mechanisms. You won't have 32 because there's a bunch with 3, and there's some with only 1 in there, right? And there's some that's regulated this way and regulated that way. So this will be an ultimate goal by the time we get done. Okay, everybody all right? All right, so we just did the hardest part of the hormones because the hypothalamus released 7 and the anterior pituitary released 6. There is not another organ that releases that many. Most of them are like 1 to 3, right? So we did the hardest part, okay? So let's take a break from the hard stuff and talk about something interesting before we get to the posterior pituitary. Let's talk about our first disorders. Ready? Okay, so let's just talk about something conceptually before we get into this disorder. So why did I not give you any disorders related to the hypothalamus? Does it never go bad? Of course it does. Every damn thing breaks, right? But if I had a hypothalamus hormone disorder, it would look like a what disorder? Yeah, it would look like an anterior pituitary disorder. In addition, I'd have a hell of a time treating it as a hypothalamus disorder because of the blood-brain barrier keeping, for instance, my medications from getting up to the hypothalamus. So a lot of times you're just like, I know the hypothalamus is screwed up, but I'm just going to treat the anterior pituitary. Does that make sense? So you don't have to memorize any of these, right? Although, just conceptually, just for a second, do you see that if you had a thyroid disorder, for instance, the problem could be occurring here, or here, or here? Yeah? Okay. So now anterior pituitary. If I have an anterior pituitary disorder of prolactin, nobody cares, right? Because you're only nursing for a short period of time, and if it doesn't work, right, either your baby dies, right, or you have another way of getting nutrients, right? But they don't treat it. Usually by the time it's diagnosed, you're done with the nursing part, okay? And if you don't release it during orgasm, you never have any difference. You don't get to compare your orgasms to other people's orgasms. Be like, was that awesome? You're like, yeah, sure. Could it be more awesome? I don't know. Okay, TSH. If you had a TSH disorder, it would look like a thyroid disorder. If you had an ACTH disorder, it would look like an adrenal cortex disorder. Growth hormone, however, is the end of the chain. This one would look like a reproductive disorder, right? But growth hormone is the end of the chain. So if you have a growth hormone disorder, it is an anterior pituitary disorder, right? I mean, it could be a hypothalamus disorder, but they would treat it as anterior pituitary. So in addition, growth hormone disorders make good pictures because growth hormone, yes? Okay, so let's talk about growth hormone disorders. Are you making too much or too little of it, and when are you making it? Will allow you to figure out what the clinical relationship is. If you have too little growth hormone during embryonic fetal development or childhood, then what's going to happen to your stature? You're going to be really short, and you're going to be short just damn near everywhere. All of your parts are going to be smaller because it is somatotropin. It's going everywhere, right? Okay, so you're going to be really tiny. If you have too much growth hormone during embryonic and fetal development or childhood, too much, what's going to happen? You're going to be gi-freaking-normous is what you're going to be, right? Now, after your epiphyseal plates close, you're not going to get any taller, right, which happens after puberty. But you can continue to get thicker, right? Your bones can get thicker. So if you have a hypersecretion of growth hormone after your epiphyseal plates are closed, you're not going to get any taller, but your bones are going to continue getting thicker, and that's called acromegaly. So let me show you pictures of all three. Okay, So pituitary dwarfism is what they call it when you have the type of dwarfism related to low levels of growth hormone during your growing years. This is the grandfather of these children, okay? And he's really tiny, but please note that he's very proportional, right? Very, very proportional. So all of his parts are relatively small. This is not like a chondroplasia, that type of dwarfism, in which you could look at someone from really far away or even a silhouette. And with the chondroplasia, it's just genetic, not endocrine, right? What happens is their torso and their head are relatively normal stature, but their long bones are shorter, right? Does that make sense? That's a chondroplasia, that's genetic, it's just inherited. And there's like, I don't know if any of you guys live downtown, the Hatch family chocolates is run by a family with a chondroplasia, a lot of the kids. It's autosomal dominant, so if a parent has it, the children are pretty likely, 50% likely to have it. Does that make sense? This is different. Here's another picture of pituitary dwarfism. These two are brothers. Notice that unless you had something for scale, you might not even be able to tell that the man on the left was a dwarf, right? Because his proportions are all pretty much the same. I mean, it's small, but you might not be able to tell that he had dwarfism. Okay, now, you don't see a whole hell of a lot of people with pituitary dwarfism in Western countries anymore because we know how to treat it. If it's diagnosed, we actually know how to make growth hormone in the lab. We used to have to suck it out of the pituitary glands of cadavers, and then you have all of those possibilities of like prion diseases. We don't do that anymore. Now we make it in the lab. And so if you're diagnosed young, then they start adding growth hormone back and treating you. But it's a peptide, so how do they have to add it back? They have to inject it, exactly. They have to inject it. So the first year that I taught in Texas, one of my students, when I met her, she was like 22 and she's about 5'1" or something. And she told me that she was diagnosed with pituitary dwarfism when she was 8 or 9, I can't quite remember. And they started treating her. So short stature is when you test your levels of growth hormone, right? And then they say, oh, okay, you actually have hyposecretion of growth hormone. And then they started injecting her. And by the time I met her, she was 5'1", which is certainly not dwarf status, right? It's tiny, but it's not dwarf status. Go ahead.
Are they smaller as infants?
Yes. Mm-hmm. Yeah, but you don't know, right, whether your infant is just a small infant or, whether. So interestingly, now that it's more readily available because we can make it in the lab, the cost has gone down on the treatment, right? And people have started to abuse it, right? So what if an athlete wanted to build more muscle mass? Growth hormone will actually help you with that. So they actually test for growth hormone in professional sports and competitive sports. And then there's some situations that are ethically iffy, in which parents have decided to treat their children with growth hormone when they do not have a growth hormone abnormality because they want their children to be bigger. So, for instance, there was a 2020, I don't even know if 2020 is on anymore. This was about 5 years ago, in which there's a family, a relatively well-off family, because this would not be covered by insurance. There's no diagnosis, okay? And they have 4 children, and the mom and dad are like super jockey jocks, right? Like big super jocks. And 3 of their 4 kids are also pretty big, muscular kids, right? But their oldest son is actually just a small person, right? Just kind of small and relatively frail. And they decide that they are going to treat him with growth hormone. And they start treating him at the same ages, 8 or 9. And of course he's in on it because if your parents make you feel like you're a freaking freak and there's like a solution to being a freak, then so they start treating him with growth hormone. And by the time they do the story, he's like 12. And he's grown a lot. He's still smaller than all of his siblings. But the reason it was 2020 special was that he didn't have anything wrong with him, right? My thought was always, I sure hope you're saving up for therapy too, because you've been given some really harsh messages to a child, right? So anyway, people have done that, and it's not actually illegal to do that. Go ahead.
What happens when they stop taking the growth hormone? Do they deplete or go back? Or
No, once your bones grow, your bones grow. So you get that amount of height. But he had normal levels of growth hormone in the first place. If you had pituitary dwarfism, then usually they check your growth hormone throughout your life. And if you need a shot, you won't need as much as you did during childhood, but you might need some later. right? But that kid didn't need any in the first place. Okay, so that's pituitary dwarfism. It can be treated. Go ahead.
It's like, how do you know when there's a disorder involved or if someone's just really small? Or...
They test the growth hormone levels.
So they know, like, if you're like, I don't know, if you have a son and he's like growing to be like 7'5", then they can tell like that might be normal?
Yeah, they totally can tell. The two big hormones that are involved really, well, before puberty. Testosterone is also involved. But before you hit puberty, the two big ones are growth hormone and thyroid hormone. And a disorder of either one of those can cause disturbances in growth. And they can treat because of disturbances in growth. So let's talk about the other one. Let's talk about pituitary gigantism or gigantism, depending on your preference. And you know a pituitary giant because Andre the Giant was a pituitary giant. Okay? You know Andre the Giant? Everybody move! If you haven't seen Princess Bride, you are not living your life properly. That's all I'm saying. Okay? And also read the book, too. The book is really good. Okay, so Andre the Giant had a lot of things going on, but one of them was he was a pituitary giant. He had, I think, a benign tumor in his pituitary. So they're not going to take it out if it's benign because you would have to replace all of those hormones. So in addition, he had the next disorder that we're going to talk about, and notice that he was enormous, just freaking enormous. And not just tall, he was also really big because after his epiphyseal plates closed, his bones kept getting thicker. So this kid is also a pituitary giant, and this is his twin brother. They are identical twins. That's a really good study right there. He also has a benign pituitary tumor. If it's malignant, of course, they're going to go in and intervene because it could kill you dead. But if it's benign, a lot of times they won't go in and intervene. So you can tell not only is he taller, but he's also bigger, right? He's like thicker, right? So that is pituitary gigantism. And he also has the next thing. You can see how much how thick his jaw is and his brow is and his zygomatic arches compared to his brother. These are their feet, those two boys. The difference in size of their feet. So what happens if you continue to secrete excess growth hormone in adulthood after your epiphyseal plates have sealed is that you get the next disorder, which is called acromegaly, which just means that your bones continue to thicken and thicken and thicken. So Andre the Giant's, the diameter of one of his fingers was about 2.5 times the diameter of mine, right? And I'm not a big person, but that's still a big freaking finger. So acromegaly will continue to thicken your bones, and it changes your appearance when you thicken the bones of your face, right? It's especially noticeable in women because part of what's identifiable in a female face versus a male face has to do with the difference in the thickening of the bone that happens under the influence of testosterone and estrogen. So I'll show you this one's actually relatively famous. This is a woman, really old pictures, watching the progression of acromegaly. She was also a pituitary giant, but acromegaly as she gets older. Look at the change in her facial structure as you get the progression of acromegaly. So it really can dramatically change your appearance. And now that you know what acromegaly looks like, you can see it in his face. Yeah? Go ahead.
So people who say that their big bone is
Well, it's potentially a thing. However, the amount of tacos you eat will not change your bone mass dramatically. Big-boned. So you can be big-boned. There's far more genetics to that than anything else. Certain genetic populations have thicker bone mass than others, which means they're less likely to have osteoporosis. In the world, the people with the thickest, biggest bones naturally are people of African descent. Way more bone mass. Way less likelihood of osteoporosis than any of the rest of us. The people with the least thick bones all over are people of Asian descent. I mean, Asia's huge, but like Southern Asia descent have the less bone mass and more likely to get osteoporosis. Okay, so now we are going to move to the posterior pituitary. Everybody ready? Okay. So back away from the fun stuff and back to the hormones. This one only has 2 hormones, guys. Not that bad. Told you you did the terrible part. Okay, let's remind ourselves of the connection between the hypothalamus and the posterior pituitary. Really, the posterior pituitary is part of the hypothalamus, right? And whatever you make up here is going to be released here. But these hormones are considered posterior pituitary hormones and not hypothalamus hormones. Although really that's just sort of like historical inaccuracy is what happened here. And so how are these hormones released? These hormones are released because of action potentials, right? And they are going to be released via exocytosis, just like a neurotransmitter, only they get picked up by the bloodstream, so they're a hormone. These are the ones that your textbook wants to call neurohormones. But I don't like that because it makes people think that they have more physiologically in common with a neurotransmitter than a hormone. All they have in common with a neurotransmitter is the release mechanism. But the impact, right, not going to be instantaneous and really broad, potentially, right? So you can call them neurohormones if you want to, as long as you remember that if you had to decide between neurotransmitter and hormone, they're a hormone, right? Okay, so they're released by exocytosis in response to an action potential. So again, this is really where the nervous system and the endocrine system come together. So you've got an action potential release. So let's talk about the two of them. I find these two super duper interesting. So the first one, do you guys remember ever looking at all of the little nuclei that make up the hypothalamus? I force my students to see it. There's like so many little, do you remember what a nucleus is? The gray matter inside the brain is little blobs of nuclei. These are just two of the nuclei in the hypothalamus, and these two specifically make and release these two separate hormones. So the first one, and you don't have to remember the names of the nuclei, these cells secrete a hormone that has two different names. Each name tells you something about the hormone. The first name is ADH. So ADH is implying, but again, not telling you the target. Antidiuretic hormone. It's implying a target. What's the target it's implying? Diuretic. Antidiuretic. Yes, that is one of the targets. Okay? And if it's an antidiuretic, does it make you pee more or pee less? Pee less. And so what would it do to your blood pressure, do you predict? Raise your blood pressure. Keep that in mind for just a second, okay? Antidiuretic hormone. Why do you usually release antidiuretic hormone? The primary trigger for releasing it, there's more than one, is that the blood that's going through your brain and comes into contact with those neurons up there is slightly hypertonic, too many solutes, not enough water. And what happens when they detect that there is you release ADH, which goes to your kidneys and makes you retain water. Also makes you get thirsty, by the way. Okay, makes you get thirsty. So you retain water. Does that make sense? Okay. The other target is implied by the other name for the hormone. The other name for the same hormone is vasopressin. So where is it implying to you that it's going? Blood vessels. Okay. So now I'm going to teach you something that's helpful with the endocrine system. Obviously, hormones quite often have more than one target. Yes? Because they're hormones, right? Here's a rule with hormones. You are never going to do something to one target and then undo it with the other target. So now I want you to try to figure out what you could do with the vessels that would be consistent with what you just said you did with the kidney. You said you just caused water retention in the kidney, right? And did what to your blood pressure? Increased it. What can I do to the vessels that would be consistent? Constrict. Yes. Okay. Can you see that if I dilated, I would have just undid what I did at the first target cell? Okay. So this is really useful for a person like me that freaking hates memorizing things, right? Because if I understand what it does here, I can figure out what it does at the other place. And sometimes that's super important. For instance, anything related to cardiovascular function might affect the heart, the vessels, and some other places, right? Heart, vessels, kidneys, right? So it could affect a bunch of different places. So they're never going to contradict what you did at one target by doing something opposite at the other target. Go ahead.
Is this going to be a pattern again where like you get not enough water in the blood and then it gets detected and then we release this hormone and
The feedback loop.
negative feedback?
Yes, it is negative feedback.
Are we going to be able to depend on that mostly for like a
Yes.
lot of these hormones?
Yes, the vast majority of these hormones will be controlled by negative feedback. The big exception is progesterone. Progesterone's weird positive feedback one. Yes. But yes, so what you're starting to see, what he's starting to do is what I want you to do. Is to start to figure out, okay, all of these are basically trying to maintain homeostasis. primary mechanism of maintaining homeostasis is by negative feedback, right? And so you detected entirely too concentrated blood, not enough water. You released ADH, right? And in addition to ADH going to the kidneys and the blood vessels, it also made you thirsty. And then give that a little while, because hormones don't work instantaneously, right? Right? Give that a little while, not seconds, but minutes or hours, right? And then what will eventually happen is you'll change the osmolarity or water concentration of the blood, feed it back, and then what will happen? Up here. Then you'll stop secreting ADH. Yes, exactly. Does that make sense? Okay, it's the same damn story we've been telling all semester. It's just like specific iterations of that story, right? Okay, you guys all right with that? Okay. All right, now let's talk about the other fun function, interesting that they've only figured out recently, of vasopressin. And for some reason, related to sexuality, they always refer to it as vasopressin. So in addition to these triggers for releasing ADH or vasopressin that we just talked about, there are some others. One of them is specifically related to sexuality. Okay, and we did not know this before about 10 years ago, and it only got into the literature about 5 years ago. So let's talk about oxytocin for just a second. You guys probably all know oxytocin and its relationship in childbirth and mother-child bonding, right? So we've known about that for a really long time. Oxytocin is also released during orgasm. Orgasm is a big chemical party. It tends to make people bond to one another, okay? And it's that sort of feel-good, lovey-dovey hormone kind of thing, with a little exceptions. I'll put an asterisk on that later. But males and females release during orgasm oxytocin and vasopressin, but not in the same proportions. Vasopressin is a different kind of bonding that is more predisposed to the male role in reproduction. Vasopressin doesn't do the lovey-dovey monogamy kind of bonding, because that is not what males are predisposed to do, okay? And I hate to tell you that, but Disney lies, okay? Females are not very monogamous either. They tend to be serial monogamous. But here's what vasopressin does, and I want you to think about how it would be evolutionarily a stable strategy in mammals and primates. When a male has an orgasm with a female, I guess with anybody, honestly, but evolutionarily we'll think about like heterosexual situations, then he releases vasopressin, but vasopressin causes a different kind of bonding. Instead of that's my boo bonding, it's that's my bitch. This is all my stuff. This is my territory. It increases territoriality. It increases aggression between males, right? Can you see evolutionarily how that would be a stable strategy? Because if you are going to raise a baby, whose baby do you want to raise? Yours. So it increases territoriality and increases male-male aggression, right? So males tend to have that sort of different kind of territorial bonding compared to females. Now, I'm not saying females don't release that. You probably know a couple females who release a ton of it, right? So we're talking about population-wide, males tend to release more vasopressin than oxytocin. Does that make sense? Okay, so they've done some cool studies. Freaking, I love this kind of stuff. I like anything related to reproductive physiology and the evolution of sexuality. So they did some cool studies in which they took males and they put them in a room and they had them play a board game. But before they had them play the board game, they dosed them up with extra testosterone and extra vasopressin. And guess what happens when you play Monopoly with a whole bunch of testosterone and vasopressin? Somebody's going to get killed on boardwalks. What's going to happen? Right? They will like punch each other. There's yelling. I mean, Monopoly makes families hate each other anyway. Every time our family starts to play, I was like, I am out. I want to see you guys again. So anyway, you can really, really increase male-male aggression by pumping up the level of vasopressin. And it's pretty interesting. We're just like a big freaking bag of chemicals trying to make another bag of chemicals. Okay, so now clinical connections before we go any further. The clinical connections here are the posterior pituitary. There is a disorder here, and there is a disorder that is a type of diabetes that you might not have heard of before. So we're used to thinking about diabetes as diabetes mellitus, which is the one related to sugar and insulin generally. Yes? That's not this one. The word diabetes means you pee a lot. Dia means through. Your pee goes straight through you like a racehorse. Okay? So diabetes mellitus, one of the first symptoms is that you start peeing like a racehorse. But so is this other one, which is diabetes insipidus. Diabetes insipidus, let's talk about the problem and then the symptom, and then we'll compare the two of them for a second. You're going to pee like a racehorse, but this time you're going to pee like a racehorse, usually because of hyposecretion of ADH. Does that make sense? Hyposecretion of ADH. If you don't have any antidiuretic hormone, you're going to have diuresis, not diarrhea, but diuresis. Okay? So you're going to pee like a racehorse. Does that make sense? Now, how, when someone presents with peeing like a racehorse, did they tell the difference between diabetes mellitus and diabetes insipidus, which is the one we're talking about right now? Well, mel means sweet because you pee a lot and your pee is sweet. And insipid, does anybody know what insipid means? What? No, it means bland, or if you want to insult somebody, you can call them insipid, which means they're bland or stupid, right? And if they're insipid, they won't know what the hell you're talking about. So bland pee or sweet pee, which means that, historically speaking, somebody had to taste the pee, right? And the reason you were in the right place in your life is because it was not the person with the degree, was it? No, it was not. It was not. The person with the degree does not taste the pee, right? So you're doing right. That's all I'm saying, right? Okay. So now they don't taste the pee anymore. And by the way, after they figured out that they didn't have to taste it every time, they could, for instance, put it out on a windowsill and see how many flies it attracted. Pee is always going to attract flies, right? If you're a country girl, you know that. But if it's sweet pea, it's going to attract way more flies. Way more flies. Okay, so that is diabetes insipidus. It is a hyposecretion of what from where? Hyposecretion of ADH from the posterior pituitary. Yes? That makes sense? Okay, and then our last one for today, I think, see how far we get, is oxytocin. So let's talk about oxytocin for a second. Oxytocin has gotten a lot of press recently. They call it the cuddle hormone, but it's way more complicated than that. Because you know if it makes a good sound bite, it ain't exactly true. It's just truthy, right? It's just like, oh, that makes for a good meme. Not exactly true. So let's talk about what's true about oxytocin, what's not true about oxytocin. We've known about oxytocin for a long, long time because of its role in birth and nursing, right? So during the whole birth part, both the mother and the child release boatloads of oxytocin, and it causes uterine contraction, and it actually causes parturition, right? So the evolutionary strategy there is that not only does it cause childbirth, but oxytocin also makes you bond, right? It's really important to bond with an infant because they are seriously not entertaining at all, and they're not even cute. Just go back and look at your pictures of your kids. You thought they were adorable. They look like angry old men when they're first born. They're not cute. But what makes you not leave them in the backyard? Generally oxytocin. And so that's a really evolutionarily stable strategy because they don't do a damn entertaining thing until they're like 6 months old, right? And really they get fun when they're 2, honestly. They're like gonna like make a joke and you know. So you release a lot of oxytocin and it bonds you to the child. And of course, I am not being sexist here, but generally speaking, which parent tends to bond with the child most quickly? The mom, because like chemistry is bonding her to the child. It is not some lack of character in the male. However, you can artificially induce oxytocin in the male by doing what? With the baby. Skin-to-skin bonding, yes. 20 seconds of skin-to-skin bonding at least, if it is a welcome skin-to-skin bonding. Right? If your brain actually says this is pleasant and not unpleasant, meaning a sexual assault ain't going to get you any oxytocin, right? But skin-to-skin bonding with someone that is a welcome skin-to-skin bonding will release oxytocin and cause bonding between the two of them. So you have to be careful who you cuddle with because you might think that you like them and you just oxytocin them, right? You don't oxytocin them. You just oxytocin them. Okay, so that is, we've known for a long, long time. 20 seconds of skin-to-skin bonding, welcome skin-to-skin bonding. But in addition, oxytocin is also majorly released during orgasm. And it causes pair bonding. Yes? And it is, of course, released in one sex more than the other. Which one? Females. And why? Why is it an evolutionary stable strategy for a female when she has an orgasm, right? To bond, pair bond with that male. Why is that more of an evolutionary strategy for the female than the male? Think about it. Yeah, because childbirth, pregnancy is really freaking risky and resource expensive, right? It's really difficult to do it well on your own. It's also really difficult to raise a child on your own, right? So what you want is you want some protection from the elements, you want to double up the resources, right? And it's not so much territoriality as it is I am bonding, right, so that we can actually do this together. So typically speaking, males release way more vasopressin and females release way more oxytocin during orgasm. Isn't that interesting? And guess what? People have been trying to figure out how to artificially manipulate oxytocin levels in other people. They're like, could I just like put this on his pillow? Right? Well, it's a peptide, so in order to get it up there, you have to get around the digestive tract, right? So you can't like dose his food, right? And I'm saying his because you know it's like a woman that's trying to do this. You're like, I can be sexist against myself, can I? There is some nasal spray that seems to work. I don't know how you like nasal spray someone without them knowing it. Because it goes, like the nasal epithelium is really, really porous and you can get it through there. But anyway, so that is oxytocin. You got to be super careful who you have sex with because, again, the skin-to-skin bonding releases oxytocin, but then orgasm releases oxytocin. And you're going to wake up 3 months later and you'll be like, who the hell are you and why are you in my kitchen? Right? You didn't love them. You oxytocin them. Go ahead.
What about pheromones?
What about, oh, this is interesting. So I always almost talk about pheromones in humans. Do you guys know what pheromones are? Okay, so this ventures into land that is almost pseudoscience, but I don't think it is, but I'll just tell you why I don't usually talk about them. So when we talk about chemical messengers, we talk about paracrine, autocrine, right? Hormones and neurotransmitters, yes? Okay. What pheromones are in other species, we absolutely know they exist. Pheromones will be released, for instance, an ovulating female will release pheromones into the air, yes? Lowish concentrations, but the males can detect the pheromone levels with this vomeronasal organ, which is related to smell, but not exactly related to smell. Ours is really degenerated, so people can't quite agree whether we have a vomeronasal organ, but we do actually react to other people's pheromones. So for instance, you can give a woman the clothing from a man she's attracted to and has had sex with, the smell of his sweat can force her to ovulate, right? Yes, it can. Males can detect ovulating women. They can detect ovulating women in the room, and they are far more attracted to them. So this is a really interesting area of study. So why the hell do we not study it? Because we don't have a vomeronasal organ, and we can't quite agree what's going on. However, it's not nothing. It is not nothing that's going on. We have all kinds of signaling that seems to be going on between us. There obviously is some signaling. I mean, have you ever smelled your own stress sweat? Do you know that your like workout sweat and your stress sweat smells entirely different, right? Other people's got to be able to smell it if I can smell it, right? So you are doing some airborne communication. And is it a hormone if it's in the air? Well, it doesn't really categorize as one, right? Is it a neurotransmitter? It doesn't fit there either. Is it a paracrine agent? No, it's not. It's not even communicating with your own cells. So pheromones. I personally think that pheromones are a really interesting area of study. It's also the reason that you can live with women. They call this the Wellesley effect because they studied it at Wellesley College first. You live with women, what will happen to your cycles?
Sync.
You're going to sync up. You're going to sync up your cycles. Why? Are you all taking the same pills? Are you know, you're like something is communicating between the two of you. So I love talking about pheromones, but I never put them in there because every time I do, somebody's like, that's pseudoscience. I really think it's just not well understood science, personally.